Hello everyone. Today's session is about overview of glaucoma. Now before really moving on to glaucoma, let us discuss some structures of the eyeball. Here I've drawn the eyeball. An eyeball is divided into two segments, the anterior segment and the posterior segment. The segment that is present in front of the lens is the anterior segment and behind the lens is the posterior segment. Now the anterior segment is again further divided into two chambers, the posterior chamber and the anterior chamber. So the space which is between the lens and the iris is the posterior chamber, and the space which is between the iris and the cornea is the anterior chamber. So it is actually the iris which divides the anterior segment into posterior chamber and anterior chamber. The anterior segment is filled up with fluid called aqueous humor, and the posterior segment is filled up with this fluid known as vitreous humor. An aqueous humor is actually the one responsible for maintaining the pressure inside the eye. It is produced by ciliary processes which are present in the posterior chamber. The ciliary processes, they will produce aqueous humor which will flow into the posterior chamber, and from the posterior chamber these will flow out through this gap known as the pupil into anterior chamber. And in the anterior chamber there is an angle you can see which is between the cornea and the iris, and this angle is known as iridocorneal angle, and in this angle there are certain structures that are responsible for drainage of the aqueous humor. So aqueous humor is produced in the posterior chamber and it is drained in the iridocorneal angle of the anterior chamber, and this is responsible for maintenance of pressure inside the eye. So aqueous humor here, it is produced by ciliary processes. From there it flows into posterior chamber and into the anterior chamber through pupil, and from the anterior chamber it is drained into a trabecular meshwork, and from the trabecular meshwork it flows into canal of Schlemm which drains into episcleral veins. So this is how the aqueous humor is produced and drained inside the eye. Now briefly discussing about the drainage system. Here I have drawn cornea in blue and iris in red, and this is the iridocorneal angle. So this space is the anterior chamber which contains aqueous humor, and in the iridocorneal angle you can see this structure. This is the trabecular meshwork. The aqueous humor will flow through this trabecular meshwork into this bag-like structure. This is the canal of Schlemm. From the canal of Schlemm it will flow into scleral veins through these channels known as the aqueous veins. So this is how the aqueous humor is drained from the anterior chamber into the episcleral veins. And as I have already said, aqueous humor is responsible for maintenance of proper intraocular pressure, and the normal intraocular pressure of eye is between the range of 10 to 20 millimeter of mercury, and this pressure is measured by tonometry. The autonomic nervous system of our body also plays a huge role in maintenance of pressure inside the eye. The parasympathetic system, it constricts the ciliary muscles, and when this happens, this will actually open up the trabecular meshwork, and this allows the aqueous humor to drain, and this will result into decrease in pressure inside the eye. Sympathetic system will stimulate the ciliary processes, and this will produce aqueous humor, and this results into increased pressure inside the eye. Now let's talk about glaucoma. What is glaucoma? Glaucoma is a group of disorders which is characterized by a progressive optic neuropathy. So remember, there is optic neuropathy in glaucoma, or there is damage to optic nerve which results into irreversible visual field defects. Okay, so you will have to remember these two things, optic neuropathy, and there is visual field defects in glaucoma. And this visual field defect is actually, there is a pattern for this. So there is peripheral visual loss. So the peripheral field defect occurs first, followed by the central vision loss. Okay, so first there is peripheral vision loss followed by the central vision loss. And this last line is also very important. Glaucoma is associated frequently but not invariably with raised intraocular pressure. So it is not necessary for the intraocular pressure to be raised to cause glaucoma. The pressure inside the eye could be completely normal, but if there is presence of optic neuropathy and if there is visual field defects, then this can also be called as glaucoma. And this type of glaucoma is known as normal tension glaucoma or low tension glaucoma. Now coming on to the types, it can be open angle glaucoma or closed angle glaucoma. So if you look into this picture, the angle between the iris and the cornea is open, and if you get glaucoma, this is known as open angle glaucoma. Whereas if you look into this picture, the part of the iris is much towards the cornea and the angle becomes very narrow, and this type of glaucoma is known as closed angle glaucoma. Now let's talk about closed angle glaucoma. It's a more rare type of glaucoma with abrupt onset. So the angle for drainage suddenly closes, and it is characterized by painful red eye, blurred vision with halos, and the eye is often described as firm eye or rock hard. And the symptoms of closed angle glaucoma can be triggered when the pupil dilates. If you go back into this picture right here, you can see this is the gap, this is the pupil, and if the pupil dilates, this iris is pushed into this direction. When it is pushed in this direction, this will further close this angle, and this will aggravate the symptoms in closed angle glaucoma. And certain conditions where the pupil can dilate includes low light situations or the dark areas, and certain drugs such as atropine and scopolamine will also dilate the pupil. And closed angle glaucoma is an ophthalmologic emergency, so if it is not treated in time, this can lead to permanent blindness. The treatment includes eye surgery, which includes laser and peripheral iridotomy, trabeculectomy. The medical treatments are not used often because they are not very effective, but they can be given for patients who are waiting for their eye surgery to reduce the intraocular pressure. So drugs such as acetazolamide, mannitol, timolol or bitoxolol, pilocarpine, and oral hyperosmotics such as glycerol can be given as medical treatment. Now let's talk about chronic angle closure glaucoma, which is a variant of angle closure glaucoma. In this glaucoma, there is gradual cynical closure of angle. So a portion of angle gets blocked, it develops scarring, and over time, the angle progressively becomes more closed. Since it's a very slow process, the intraocular pressure is not very high, and hence there is fewer symptoms such as pain, and this results into delayed presentation. And when there is delayed presentation, there is already more damage to the optic nerve, and the diagnosis for this is made when there is peripheral vision loss. Okay, so remember, in glaucoma, first there is peripheral vision loss, and then it is followed by central vision loss. Now let's talk about open angle glaucoma. It's a more common form of glaucoma, and it's chronic disease. So most patients have this form of glaucoma, and it is characterized by slowly progressive raised intraocular pressure. And unlike that of closed angle glaucoma, here the angle of the anterior chamber is open and normal. So there is open, normal appearing anterior chamber angle. And since the angle is open, the raise in the intraocular pressure might be due to either overproduction of fluid or too little drainage of the fluid. And there is characteristic optic disc cupping and specific visual field defects. So the specific visual field defect is peripheral vision is lost first, followed by the central vision. And often patient with this type of glaucoma, they go into chronic drug therapy. Open angle glaucoma is associated with different factors such as age. With increase in the age, there is increase in risk for getting open angle glaucoma. However, it is very common in age between 5th and 7th decades. It is also associated with family history, where there is 10% risk in the siblings and 4% risk in the children whose parents have open angle glaucoma. And talking about the race, the open angle glaucoma is significantly more common. It develops earlier, and it is more severe in African Americans. Now let's talk about the types. Primary open angle glaucoma is when its cause is unknown or unclear, and secondary open angle glaucoma is when it is associated with other diseases such as uveitis, which is the inflammation of uvea, trauma, or steroids. It is believed that steroids reduce the drainage of the aqueous humor, hence this can cause glaucoma. Or if you have a history of retinopathy, then this can also lead to glaucoma. Now let's talk about one of the characteristic feature of glaucoma, which is disc cupping. So before really talking about this, let me draw a very rough sketch of eye. So this is eye, and this is the cornea. We know that the inner layer of the eye is lined by retina, and from the retina there are certain nerve fibers that are rising from the ganglion cells, and these nerve fibers, they are directed to a point, and from this point they are these nerve fibers, they come out of the eyeball, and this point right here is known as the optic disc. Okay, so if you look into this diagrammatic representation, this yellow structure is the are the optic nerve fibers that are coming out of the eyeball, and this structure from here to here is the optic disc. And if we correlate it with this picture above, so this is the actual picture of the optic disc when we look through the fundoscopy. And there is a depression in the middle of the optic disc. It's a cup-like structure. This is known as the optic cup, and it is represented by this bright area in the middle of the optic disc. So if you look into this actual photograph of the optic disc, this outer circle is the optic disc, and this inner brighter area is the optic cup. And if you look carefully, the diameter of the optic cup is almost half or less than about 1/3 of the optic and disc. So this is the normal one, whereas in case of glaucoma, the size of the optic cup, it increases due to pressure inside the eye. So the optic cup, it becomes more deeper and it increases in size. So the optic cup in glaucoma, it becomes like this. It becomes more deeper and it increases in size. And if we do fundoscopy, you can see the brighter area in the middle has increased in its diameter. So this is the glaucomatous change in the optic disc. So, and this is known as disc cupping. Now let's briefly talk about some chronic glaucoma drugs. The first group here is parasympathetic mimetics. This includes pilocarpine and carbachol. These are muscarinic agonists, and they act by contracting the ciliary muscles, and this will open up the trabecular meshwork and leads to more drainage of the aqueous humor. Next group is alpha agonists, which includes brimonidine and apraclonidine. This drug will decrease the production of the aqueous humor by blocking the ciliary epithelium. Beta blockers include stimolol, bitoxolol, and cartiolol, and the mechanism of this drug is similar to that of alpha agonist. Next group is prostaglandin analogs, and drugs in this group, they end with prost, so it includes latanoprost, travoprost, bimetoprost, and tafloprost. And these drugs, they increase the UV scleral outflow of aqueous humor. This is another pathway through which the aqueous humor is drained out of the eye. Carbonic anhydrase inhibitors, the topical ones includes dorzolamide and brinzolamide. They decrease the production of the aqueous humor. Oral carbonic anhydrase inhibitors includes acetazolamide and methazolamide. These drugs are less commonly used because of their side effects. However, they can be given to lower the intraocular pressure for short term. Now the last group of drug is adrenergic drugs, which includes epinephrine. We know that epinephrine have mixed action, both alpha and beta agonist. In its early effect, it will increase the aqueous humor production due to its beta effect, whereas in its later effect, this will vasoconstrict the ciliary body, which will result into decreased production of the aqueous humor. And also, in its alpha action, it will stimulate alpha receptors in the aqueous outflow system. This will increase the drainage of the aqueous humor. However, this drug is associated with high allergic reaction rate, and it is also considered as one of the risk factor for failure of filtration glaucoma surgery, which is one of the technique for treatment of glaucoma. Hence, this drug is no longer used as first or second line drugs. And also, remember never to give this drug in closed angle glaucoma, because it will dilate the pupil and this will worsen the angle closer. So this much is for the glaucoma. Thank you.